Now, let's talk about some degenerative CNS disorders. We're going to be talking about multiple sclerosis, Parkinson's disease, and Alzheimer's disease. We are going to start first with multiple sclerosis. I don't know why though they call it multiple. We don't have single sclerosis. Maybe because we have multiple neurologic disorders, multiple neurologic manifestations. MS is a relatively common acquired autoimmune inflammatory disorder involving degeneration of the axonal myelin sheath in the brain and spinal cord. What is the myelin sheath? It's a lipid covering that covers the nerve fibers, and it helps the fast transmission of nerve impulse. If you have degeneration of this myelin sheath, the nerve impulse is going to travel slower than normal. When this happens at scattered points in the brain, you will have a lot of neurologic manifestations. So MS is going to present with abnormalities of any part of the CNS, and this will improve only to have another defect develop several months to years later. The most common abnormality is optic neuritis. You get visual affection, but you can get motor problems, you can get sensory problems, you can get sphincteric problems, bladder, atonic bladder, or any sphincteric problems. Also common manifestations, common features in MS is fatigue, hyperreflexia, spasticity, and depression. And as you can see in this diagram, the course of multiple sclerosis is always progressive, and during this progressive course you can have bouts of exacerbation followed by remission, but you never get back to normal. You always get back to even a lower or a worse condition than before. So MS is a progressive degenerative disorder of the CNS. The best initial diagnostic test is going to be MRI, which is also the most accurate test. Do we need to do CSF analysis for the oligoclonal bands? Only if the MRI is not so conclusive, then you can do CSF analysis, and we search for these oligoclonal bands as you can see in the diagram. Other than that, MRI is the best initial test and the most accurate test as well. Treatment of MS. Steroids are the best initial therapy for acute exacerbations. When the patient has excessive worsening of symptoms, this is the time for steroids. And we can use disease-modifying therapy like beta interferon, glatiramar, and methoxatone, and natalizumab. Natalizumab is a monoclonal antibody. And additional medications for other symptoms: amantadine for fatigue, baclofen for muscle spasticity. Our case study, we have a 40-year-old woman with an 18-year history of multiple sclerosis. Her chief complaints today is what? Numbness on the left side of the face and tongue, and progressive weakness in her right leg, and also she has constipation. The patient's past medical history showed 6 attacks of multiple sclerosis over the last 18 years. Identify 4 risk factors in this patient that are consistent with multiple sclerosis. Here, the risk factors in this patient: female gender. Unfortunately, MS is twice as common in females as in males. Age at the time of onset. First symptom of MS most commonly occur between the ages of 20 and 40, and this what happened with this patient. Northern European ancestry. The patient comes from a Belgian ancestry, and the patient was raised in Great Lakes region, a region associated with increased susceptibility to MS. So we have here the 4 risk factors for MS in this patient. What probably precipitated this most recent attack of MS in the patient? That was what? Bad cold. Bad cold may have triggered the current relapse because it lowers the immunity. Does the rectal examination provide any information that helps in this or that supports the diagnosis or the effect of MS on the patient's constipation? The answer is yes. Diminished anal reflex suggests that the nerve conduction at the anal rectal region of the GIT is diminished because of, again, MS. MS is a degenerative neurologic disease. Decreased nerve impulse transmission to the sphincters will lead to sphincteric problems. Why is lymphocytosis in the CSF consistent with an attack of MS? During episodes of relapses in MS, the T lymphocytes cross the blood-brain barrier into the CSF. And once within the brain and spinal canal, these cells release cytokines that attack and activate macrophages, and these cells can directly cause demyelination of the nerves. So the T lymphocytes are the source of the trauma that happens and the degeneration that happens to the myelin sheath, and you get worsening of symptoms when you degenerate your own myelin sheath. So you expect to have a lot of lymphocytes in the CSF during the acute attacks.